Gecko is of the University of New Mexico, or ECHO is, supported locally by the Gastro Foundation. And we have these meetings weekly. And today it's the turn of pediatrics. So I'm very pleased to be able to welcome Miranda McDonald onto the platform. So first time here, but hopefully not the last, because she's our local allergy expert in Johannesburg, and we're very grateful to be able to work with her. What we're going to do today, I'm going to start off with a case, and then Miranda will take over from there, and hopefully we can generate some discussion. As always, the chat is open for questions, or otherwise raise your hand afterwards and we can discuss. All right, so let me kick it off with a case presentation. And I just have to put this in presentation mode again. Sorry about that. Now that all my buttons are hidden. Okay, there we go. So the case presentation is a real case that I actually want input on, Miranda. So it's not a straightforward, here we go, this is the topic. But maybe the more perceptive of you will look at the slide and already know what we're going to talk about. So the patient in question is actually a 5-year-old girl. And I put there, she's on an atopic marathon, because a march is really an understatement here. She's got asthma, she's got allergic rhinitis, she's got eczema on topical treatment, and then she's also got some IgE-mediated allergies. She reacts immediately on exposure to fish or peanuts, and what happens then is she gets an immediate itchiness of her face and urticaria, allergic wheals. And she's had a battery of tests already. Specific IgE was done and raised around 50 for codfish and peanuts. And we saw her at one of our combined allergy GI clinics. And she also was noted to have picky eating and growth faltering. And we were wondering if there was more going on. Perhaps she had eosinophilic esophagitis. So when we saw her as a gastro team, Mom described her as a picky eater. She drinks water after each bite to get it down, which is always a question that I ask specifically when I want to know about dysphagia. And I'm not sure if it tends to spoon feed them too much, because a lot of the time they say yes to that, even though they don't volunteer it initially. She didn't have any vomiting, regurg, no food impaction. She's quite small still. She had been losing weight, and her weight for length at this stage was on the -2Z score, so she was borderline wasted. At the time, she wasn't on a proton pump inhibitor, so we planned our gastroscopy. And I'm afraid these pictures don't look much like what we saw at the time. I took them from the hard drive. But what we saw is we saw some furrowing in the top left. I hope it shows a little bit that there were these linear furrows along the esophagus. And then closer to the Urge junction, she also had these little plaques, which we were wondering if there could be eosinophilic abscesses. So we biopsied her, and this is where the confusion came in a little bit, because we've received the results. And in the lower esophagus, which was specimen A, they did see numerous eosinophils, more than they should be there, with eosinophilic exocytosis and degranulation, along with the other changes that we expect to find. But in the upper esophagus, unfortunately, they didn't comment on the eosinophils. And I have to presume that that means that they didn't see significant eosinophils in the biopsies. So it looks more like this was reflux esophagitis, at least in the upper half of her esophagus. So I think that's where I'm going to end and hand over to Marinda. She isn't a clear-cut case of what we're going to discuss, but I hope she can provide some discussion points. Thanks, Marinda. Go ahead.
Thank you, Tim. And thanks for having me. Full disclosure, I'm not a pediatrician. I'm an GP with a diploma and a certificate in allergy, and I work with Tim at Rahima Musa. We've got a lovely little clinic we've built up there, and I'm in private practice. So I should have concentrated more to the WhatsApp group and Tim's messages. So my case study and his are maybe similar to a certain degree. And I think what my goal was here is I took the British guidelines, I took the ESPGHAN guidelines, kind of merged them. And my second last slide will be what we are going to try to implement at Rahima, because it's fantastic to have all of these things. And then in a resource poor setting, we are faced with less easy access to care. And even the regular scopes is, not something that's as practically possible, although I think that we should endeavor to get there. This is just the overview. We might veer off from that, but we're going to talk about the prevalence, the diagnosis, the treatment, the topical cortisones, PPIs, the place of diet, and that's changed dramatically, dupilumab, and then long-term maintenance. As I said, I have references at the end, but most of my, unless stated at the bottom, slides come from here. So I want to start with my own case study. And this is a boy. He could be 1, 2, 6, 10. I've got numerous kids in this process. He starts with a poor weight gain, and that's where I say the similarities to our cases. He's a picky eater. He never finishes a meal, and he's a pretty unhappy baby or a child. And it's very easy if a mum comes in with a baby to say, it's a first-time mum, and I never always feel sorry for the gastroenterologists, because they are the gatekeepers of this condition, and they have to face all these desperate mums, and some of them are moms that aren't coping, but some of them are kids with organic disease, and it sometimes seems to me like throwing the bones, who's going to get a scope or not. So this baby went to the pediatrician. The pediatrician referred to the dietitian for dietary assessment and a meal plan. This took about 4 weeks from the consult, to get the meal plan, to institute it, 12 weeks to kind of see if the child is now going to start growing, because is this just a child that's got some feeding issues? And I think not every picky eater is an EoE. So it is a warning sign, but we need to give them a good, I always see it as a pyramid, and my job here is to fill the base of the pyramid. So by the time they get to the gastroenterologist, we've done the hard work. We've done the, let's go through a healthy diet. Let's look at your basic dietary plan. This kid's next visit was 6 months later at the ped. It only gained 150 grams, still an unhappy baby. And then, there's always this possibility a trial of a PPI is put in, because the mum's putting pressure on the pediatrician. And the pediatrician at the same time then decides to do allergy test. They then wait or they do the test, then it's referral to an allergist if they have one. Otherwise, it's the pediatrician interprets the results. And then also reviewing peripheral eosinophilia, if there's any concept of that. And then as well as a total IgE. Then it depends on if this child was lucky or not, but then usually if you grow up in Gauteng, you have, because of our high GRAS load, you'll have children with a very high GRAS score. They will then get a peanut, wheat, soy that's positive. That's the profilin, so it's a false positive. these children invariably are then put on these diets, where they then remove peanut, wheat, and soy in children that were eating it previously. And the question now is, with this child, so now you're putting him on the diet, must he now be weaned off the PPI? Is the child better or not? The next review, the child has had minimal weight gain. His Z score is edging closer to -2. And then at that stage, maybe he'll get a referral to the gastroenterologist. And then it's a discussion around, should we do a scope? Should we not do a scope? Does this child justify it? Maybe 1 or 2 more pediatric visits. And before you know it, 12 months has passed. And this is not unusual. This child then did have EoE. So eosinophilic esophagitis is characterized by symptoms of dysphagia, food impaction, feeding problems, abdominal pain, and or vomiting in children with esophageal histology showing a peak eosinophil count of more than 15 per high power field or per 0.3 millimeter square millimeters. Now that is whether you are reading your eosinophils in analog or digital, that the count of the eosinophils. Non-response to PPI is no longer part of the definition. EoE was described in the 90s, but what we are still seeing is a delay to diagnosis of about 10 years. And these children can have dire health outcomes in this process and have massive costs associated with their condition that is not necessary. There's definitely an increasing prevalence. There's a higher male to female ratio. 3:1 is the British ratio. The Espegan ratio is 2:1. Boys just have more. Maybe your index of suspicion should be higher. We see it in girls, so it's not that it's only boys, please. And then there's definitely this T2 barrier dysfunction. And the EoE came out with a new classification, and it now has the 5th grade 5 immunological classification is epithelial barrier dysfunction, and EoE is classified in there. So we're dealing with a child that has an entire immunological system geared towards this T2 inflammation. There can be seasonal variability. This we often see in older children and in adults, not so much in the really young children. There's a polygenetic heritability. In the nuclear family, there's a 2% heritability. First degree relatives, there's a 64% times increase, and in monozygotic twins, 41%, in dizygotic twins, 22%. So if one family member has, you need to keep your eyes open in the other family members. The delay to diagnosis is significant, and if you look at the EoE Connect papers, they feel pretty satisfied with themselves that they went from a diagnostic delay of 12.7 years in 2007 to 0.7 years in 2017, but it's kind of crept up to 2.1 years. That's in 1,100 patients. And they did feel that there was gastroscopies, all had biopsies, which I often see is that patients will have gastroscopies with no biopsies. And then unfortunately, I have to resend them for biopsies, and reduced number of allergy tests. At the same time, so that was published in 2023. In 2021, there was this paper of the Swiss. They were doing much worse. They had a delay to diagnosis of 10 years. Either way, the delay to diagnosis is not, I think, always because of poor care. It's because the diagnosis is basically only made by quite a big intervention. And as gastroenterologist, you kind of always are, does this justify it? And my last slide, maybe we can just have a bit of comment on that. So this comes from Espegan. I like things in boxes. So there's a discrepancy between symptoms and histological features. So this is just as we go along. So the patient, you see it both ways. The patients might resolve histologically, but not symptomatically, or they might resolve symptomatically. You go in and they're not resolved histologically. The reason we need them to be resolved histologically is to prevent the fibrosis. And allergy testing is of no value. And there's no place for targeted elimination. EoE may cause stenosis even in pediatric patients, and maintenance therapy is necessary. So even if the child is better, they need to stay on maintenance therapy for at least 1 to 3 years. There are validated tools for assessing symptoms of quality of life and should be incorporated, and that might help us in this decision to do the first scope, not the repeat ones. They talk about this in terms of the repeat, but my drive will be that we get these children to their first scopes earlier. Systemic steroids might be helpful in the treatment of strictures in the children that you can't dilate. And there's a discrepancy between eosinophil depletion and symptomatic improvement, and requires a reassessment of non-eosinophilic inflammation. And implementation of programs for transition to adult care must be considered as well. And that's always a problem in pediatrics. So the diagnosis, I've got all the symptoms here, and they present quite differently. So adults 46% present with this food bolus obstruction. I think they just carry on, and the dysphagia, they just kind of forge through it. But 46% of patients with food bolus obstruction will have EoE. So if you get a patient with food bolus obstruction, you do need to do a biopsy. Dysphagia, 22% of patients with dysphagia will have EoE. Again, not every dysphagia is an EoE. 7% of reflux patients, chest pain. And it's the slow eating, drinking copious amount of water, and then the patients with asthma and T2 inflammation. If we go to the children, in the under 6 group is feeding difficulties. And you know, if we think that this is our decision point to go and do a gastroscopy, a feeding difficulty could be anything from a baby that cannot latch, to a baby that vomits, after every feed, to a baby that refuses to feed because it's got bottle aversion. There are many things. So it's a very broad term. Failure to thrive and vomiting is you can see is in the older age group, the vomiting specifically. The failure to thrive, that's kind of maybe Tim's patients, abdominal pain in the older age group. And then your food bolus obstruction. So these kids have now been delayed in their diagnosis, and now they present at 12 with a food bolus obstruction and dysphagia, far more like adults. So that just makes them much more susceptible. So there's 2 indications to go and do a gastroscopy, an endoscopy. The one is with your food bolus obstruction, if you can, 6 biopsies. Now, I'm not a gastroenterologist, but they need to be done in the higher as well as lower sections, in active disease sites and not active disease sites. And then in an elective setting, that would be for your slow eaters, drinking lots of fluid with meals, food avoidance, children who bread often gets stuck, and bread might not be the eliciting factor, but some children really don't like bread. Dysphagia, chest pain, heartburn, and then also food bolus obstruction that they resolve with a variety of very inventive measures. In children, poor growth, nausea, vomiting, epigastric pain. This comes from the British guidelines. So what's really important is that the PPI is stopped. Oftentimes children will be on PPIs and then they're scoped. And then it's actually of very limited help. There is a histology scoring system that you could potentially use, but the ideal is to be off a PPI. My question here is, and I couldn't find it anywhere else, if the child is off dairy, and we know that up to 50% of children respond to a dairy-free diet, should we not put the dairy back? I'm talking specifically the really young ones. But then on the other hand, if they symptomatically better off dairy, are you going to scope them? So that's, that's kind of the wormhole you enter into. If they have more than 15 eosinophils per high power field, that's diagnostic of EoE. If they have less, then it's exactly, do we have a gastroesophageal reflux? and they should be investigated more, or are they a partially treated EoE? And should we confirm that they're off their PPI for 3 weeks and then rescope? And then consider the repeat scope, or if they are not offered, then you can withhold it. So you get a variety of appearances. I think all the gastroenterologists will be more familiar with this. I know the little pictures. I don't go in and see, but they up to 21% of kids will have a macroscopically normal looking esophagus. So it's really important to, even if it looks normal, there's an entire world below the mucosa. Mucosal granularity is in 42%. You get rings, exudates, furrows, and strictures. The strictures is kind of the easiest one to decide. 6 biopsies at 2 different levels. Because eosinophilic infiltrates is patchy. It's not the whole area will have it's patchy infiltrate. Withholding the PPI for 3 weeks is important. And it's important to understand that responders to PPI and non-responders are clinically, histologically the same disease. So it's not of any diagnostic importance if they are PPI responders or not. But it might be associated with other diseases such as reflux. EoE and GERD are not mutually exclusive, and both can exist in the same patient, just to make life easier. This is just some pictures, the edema and then the exudates. I hope there's no green colorblind people because they won't be able to read, but they can look at the pictures. Furrows and rings, and then the stricture there right at the bottom, you can see that. So the histology is 15 eosinophils per high power field, and it's the highest eosinophil density area. But then there are areas that you can see that has the severity of the tissue damage. That's the basal cell hyperplasia, the edema, the eosinophilic microabscesses, eosinophilic layering, and then the degranulation. It measures the disease severity as well as the disease, the extent of the disease tissue. And this eosinophilic esophagitis histological scoring system was published in 2017. Now, ESPGHAN feels that it's really helpful, but they don't feel that it's necessary for the diagnosis. I think if we can get our pathologists to give us more of this type of information, maybe Tim's, if they had used the scoring system, we would have had a bit more information in that child of Tim's. And then here, the white asterisk, I don't know if you can see my little arrow there. That is an eosinophilic abscess. And then the arrows, the arrowheads is dilated intracellular spaces there. And then the surface layering is there. I must be honest. I think it's clearer if you're a pathologist. Okay, so this is the scoring system. It's in the publication. It's a bit tricky in that 2017 publication to get this. It's in the addendum, so you'd need to just go look. But you basically just score how many eosinophils you've got and what you get, and then you've got your scoring system. What's nifty with that is when you then go back, you can see if the tissue damage is improved. So now you've made your diagnosis, you have or you don't have the histological scoring system, and now we treat it. Now, there's been, certainly since I've started treating EoE, there's been so many iterations that sometimes I get lost still. But the ESPGHAN was very clear in their advice. This is the British diagram, and I might come back to that. Let me just look. But what ESPGHAN basically has said is that there's no difference between any of the pharmaceutical treatment. So whether you choose a PPI or a topical steroid, there's no difference in the outcome. And that's really important. I think dietary advice is basically fallen by the wayside. I think it's in a very select group of patients, maybe your cow's milk protein allergy responders in a really young cohort. Getting a 6-year-old off dairy, that's not going to have an anaphylaxis is nearly impossible. A child with anaphylaxis, that self-regulates it, but a child with that's just going to get tummy ache, it's really difficult to get them off it. So dietary advice, and but we'll go through that. And there are people, and sometimes I get patients who vacillate. They'll insist on doing their dietary elimination. We'll do it, they'll get their scope, they'll be better, and then they'll find it's not sustainable. Then they'll go to the PPI, and depending on which AI bot they use to get the information from, they might vacillate back. So it's got a massive quality of life impairment. And I think if we have empathy with the patients in their journey around this, that their decisions do influence our decisions in this process. So you've got in your medication, you've got your proton pump inhibitors, and you've got your topical budesonide, which is 1 milligram twice a day. This includes adults. I'll give you the doses for the children, but you can just look them up. And then if there's more than 15 eosinophils after you've treated, you need to see whether they're taking their medication. You need to consider it a failure of treatment, and is there anything, other coexisting pathologies. If there's less than 15, now you'll see in the studies also, the patients with less than 15, and less than 15 could mean 14, they go on to maintenance, so we reduce their dose, and then we can do dose reduction, and those patients will be followed up. But I feel that a big part of our patient population gets lost in that follow-up, that if they do get a second scope, so sometimes it's just, okay, we've crawled to the end point, yay, we've got a diagnosis. And then to have the discipline to 8 to 12 weeks later to do your re-scope and re-biopsy, and then to 8 to 12 weeks later to see if there's a response, to redo your biopsy. You really need a disciplined team and a disciplined approach. And I think that discipline, and also getting the medical aids if the patient's in private to get them and get space on a list. So it's a novel idea. Sometimes it's not really easy to execute. Again, there's a moderate association between clinical and histological remission. You only start one modality, either pharmacological or diet. Diet and pharmacological treatment together is reserved for patients who fail monotherapy and who have access to trained dietetic support. The studies for remission vary. So some say less than 15 per high power field, others say less than 5. And there is a validated scoring system available, which this is in Espegan, and I've got the link there. And this is that measures the severity, and this is probably what one should also decide on your decision to take these patients for gastroscopy. So you can see it's got frequency of symptoms, severity of symptoms, and then it goes down to chest pain, heartburn, stomach ache, trouble in swallowing, food that gets stuck. Do you need to drink a lot of water? How often do you vomit? How often do you feel nauseous? How bad is the pain? And you can see there's a whole system there. That link is in the notes. Okay, so your drugs would be PPIs for 8 weeks at least. Once you increase it to 12 weeks, your remission rate increases. And I think in a setting where we might struggle with resources, a 12-week treatment at higher doses is possibly just a more pragmatic one, so that you are sure you'd get remission instead of going in at 8 weeks and then needing to go in maybe in 8 weeks further. There's no difference in the outcome between swallowed budesonide and a PPI, and Espegan advises either one of the two. Budesonide is in South Africa not only available, it's not available in the slurry form. In the US, they've got a slurry form. But what you could do is you can take what they use for the nebules. This is, of course, off-label, and if it's in children, it is off-label, so you'd need to discuss that with the parents. But you take your dose and you mix that either with honey or applesauce. I always think the Americans love applesauce. I think honey is more sticky. That's just a practical thing. But there's no difference between budesonide and fluticasone. One or two studies that show that, but Espegan feels that there's no difference between the two. Your fluticasone inhaler, you at least have an inhaler, which makes it easier. You do need to calculate the children's total cortisone burden if you do opt for a topical cortisone. And then an oral cortisone can be alternative to dilatation. And our dupilumab is an option. Dupilumab costs, certainly in South Africa, it costs 24,000 a month. So it's not really something, and I don't think it's been registered for EoE in South Africa. It's got registration for asthma, nasal polyps, and eczema. So you'd struggle to get funding for that. Then Espegan advises against allergy testing, and they advise, they don't, I'll show you the British one next. They advise dairy, gluten, and egg as part of an empiric avoidance. You do get a 2, 4, and a 6-week avoidance, and definitely with an elemental diet, you get a great response. But the sustainability of it and the cost of an elemental diet is, I don't think is really what one should be going for. I think that would be in a child with resistant that you cannot seem to resolve, and your goal would be to get them onto some form of pharmacological maintenance. Okay. And then Espegan recommends induction treatment of childhood EoE with a PPI, elimination diet, or topical steroids. And they have no evidence of preference. They do advise a maintenance period for 12 months and a follow-up gastroscopy 1 to 3 years to evaluate your maintenance. They recommend dupilumab can be used in select cases of children over 1, weighing more than 15 kilos. And that's in children with EoE refractory to conventional treatment and concomitant atopic burden with approved indications for biologics. And then what's really important is that I think is that we should not, these children have had a really costly journey. It's a very difficult journey. There's no indication to put them on leukotriene receptor antagonists or cromolyn sodium or sodium chromoglycate. And please, it really just, it's just polypharmacy, and it's not going to make anything better, maybe a runny nose. But Montelukast comes with so many side effects that it's a drug that should be used with great caution and not just as a safe alternative. And depends what you read, but basically 50 to 70% improvement on monotherapy. That would be your PPI or your budesonide. If you look at less than 5 per high power field, then it reduces significantly. That you'd get between 33 to 40% remission rate. If you extend the duration, you up it again. And that's why I say maybe in a resource poor setting, aiming for 12 weeks initially for me would be probably what I would go for. And there's no difference between the different PPIs. Espegan advises, and these ones with you can see the font is slightly different. I copied and pasted it specifically so that we would have exactly what they say. So they have omeprazole 1 to 2 milligram per kilogram divided in 2 doses up to 20 to 40 milligram daily. One of the things about non-responders is, and it was interesting that it's in here, and I found that in another paper, but is that with pharmacogenetics becoming available, we need to understand a bit about the pharmacogenetics of our medication. And PPIs are metabolized in cytochrome P450 in a spot called CYP2C19. And if you get 3 types of metabolizers, you get fast metabolizers, you get slow metabolizers, and you get normal metabolizers. There's also variants of that, but that's the gist of it. And if you look at these ones with this star 17, these are associated with a poor response. And those patients, so if you suspect that your patient is a poor responder because of that, you can have a pharmacogenomics panel done. It helps patients with a variety of medications if you understand their pharmacogenomics. It's not so expensive. It's about 2,300 Rand at either the places that we usually use would be Empath or D-Analysis. But there are, I'm not aware of everybody else doing it. There's a huge amount of these available in abroad. We sometimes use some American labs for our primary immune deficiency patients, but the pharmacogenomics, certainly in South Africa, you can't do that panel alone. It's part of a whole pharmacogenetics panel. If you can do it alone, the cost would be significantly less. So you get your budesonide slurry and you get your inhaled fluticasone. There's no difference in the outcomes. If you do swallowed topical steroids such as viscous budesonide and swallowed fluticasone, and it can induce and maintain remission. There's no clear evidence, and that's just the slurry if you want to make that. But the children's total cortisone burden must be calculated. So if the child is on high-dose inhaled corticosteroids, they've got extensive eczema, and they kind of have an asthma flare once or twice a year, they're getting oral prednisolone, I probably would think that one would opt for a PPI instead of a topical cortisone. And then your dietary management. What's really important is that we don't do targeted dietary elimination. There was a time that we did do that, and I think it's been quite clearly proven that we shouldn't be doing that. A 2-week elimination, a 2-food elimination diet would be wheat and dairy. Certainly the dairy, you're going to get about a 50% resolution, depends on who you read also. A 4-week would be milk, wheat, egg, and soy. 6 food would be milk, egg, wheat, soy, peanut, tree nuts. You're going to get a 74% remission rate, but a very unhappy child. Elimination diet of 92%. What I can, that's not elimination, that's elemental diet. What I can say here is that you also need to consider is that if you have a young infant or a child that's not had fully introduced all of their allergenic solids, it's possible that you can have IgE disease and what we call non-IgE disease. So it again makes it more complicated if you're now removing peanuts and tree nuts. And because we understand that we need to be eating peanuts and tree nuts, certainly from 4 to 11 months until they're 5, to prevent IgE food allergy, and now you're removing it. And I don't think there's a right or wrong answer. I think it's an absolutely individualized answer, the cortisone burden versus the PPI versus the dietary elimination. And this is made jointly with the patient. What is the family situation like? Certainly, if you're doing a 6-food elimination diet, the patients we have at Rahima, they struggle with that. We have to help them with food and formula, and we have to give them additional resources because financially they can't afford that type of food. And this is just to remind you that after every single one of your, so if you've done a 2-food elimination diet, you need to do a gastroscopy and to see whether the patient is in remission. And then if you want to reintroduce, you reintroduce it for 8 to 12 weeks, and then you rescope, and so forth for 4 and 6 food. So from that perspective, also, it's more costly. Whereas if you induce remission with your pharmacological agents, you've got remission, you reduce the dose, you do 1 scope, and then you do your next scope as you're monitoring these patients. We do taper the PPI from 2 milligram per kilogram per day to 1 milligram per kilogram per day. And you can then, if they have a relapse, you can increase it again. And any change in their plan, the patient needs to be rescoped. And then this is my all in gray, because my software, my practice gives me, if I do something moderately well, in gray. And I think this is kind of, I tried to put a storyline together, and after reading these guidelines, and I always think that we try to aim for as close to the guidelines as we can, because certainly there's a reason for guidelines. And then when you actually go into the granularity of these patients, of the repeated visits, the discussion, and certainly every time we have a joint clinic, should we be doing the gastroscopy or not? And I think certainly for me, the big lesson of today would be that this first block is that one uses a validated tool here. And if one starts to use validated tools, one would become more comfortable with the validated tools in making your decisions of who needs to be scoped. And certainly then I do believe that we'll have a reduction in our time of delay to diagnosis, and not have too many negative scopes. And here I've just added the children, oftentimes, I personally would want them on Cowsmilk or for PPI. And then you can decide if you're going to. We certainly would only do one food elimination initially, and see if there's an improvement. If not, we'll do a 2 food. But we, just from a resource perspective, we try 1 food, initiate high dose PPI. And I think sometimes we fall out of the bus here at the rescoping, just again because finding time on slates, budgeting problems. And but I do think one should get into a tighter schedule here. And then once you have remission, you can continue on your PPI. Or if your cow's milk protein induced it, we keep them on a cow's milk protein diet for a year, and then we start them on cupcakes, and we do a non-IgE updosing for them. And then I don't think we always scope enough there. And then if we have a failed therapy, you could remove the cow's milk. I said at 2 years, but definitely by 3, they're going to be eating their brother's yogurt and stealing an ice cream. And if they have an anaphylaxis and they steal an ice cream, they're not going to do that again. If they eat the brother's ice cream, they just have a sore tummy. It's much less severe. And then we'll add, possibly here, we'd add our inhaler. So, as I said, that's maybe just an interpretation of the scopes, and more of a real life type of situation. Summary: eosinophilic esophagitis is raising in prevalence. There's histologic and symptomatic improvement don't necessarily correlate, meaning that we do need to do repeated gastroscopies. Pharmacological treatment is PPI, topical cortisones, and biologics. Once remission is induced, maintenance therapy is for at least 1 year, and it's advised to evaluate your remission. Follow-up endoscopy review should be done to confirm remission, and 8 to 12 weeks after any therapeutic intervention, like reducing a PPI or introducing a new food, they need to be rescoped. Cortisone burden must be evaluated in these children. And treatment also depends on access to resources, and food is a resource, as well as patient preference. Thank you. And happy to take questions if I am able to answer them. I'm going to stop sharing. Shall I stop sharing?
I think it's okay. We can see people. I don't see any hands at the moment, so I'm quite conflicted about this group of young infants who are not gaining weight particularly well, and who have got feed aversion or regurgitation. And I think certainly the European guidelines seem to push to scope and to consider EoE quite early on. So I think I want to echo your call that we need to have some sort of scoring system to decide who we're going to scope and who not. I think, as you know, it's a limited resource both in the public and the private sector. So it's always a difficult decision, but I very much appreciate your plan of action slide at the end there, even if it's in gray.
Tim, can I ask you?
Yeah, sure.
In those infants, if you have this failure to thrive infant, feeding aversion, and would it be certainly in an under 1 year old that's formula fed? I'm not talking about a breastfed infant. If one were to put them on an extensively hydrolyzed formula or an amino acid formula as a pragmatic approach, I'm not talking about by the book guidelines. Let's say there's a delay to seeing the gastroenterologist because there isn't an access to care necessarily. And I do want to qualify that with the provisor that at some point we do put it back. So for non-IgE, it would be to put it back after a month. So that's the diagnostic criteria for non-IgE cow's milk protein. And if it is non-IgE, then EoE is non-IgE. So you would then remove it for a month, put it back in, and then at 1 year, review it and possibly start this child either on the milk ladder or with another milk challenge, and provided they haven't become IgE, and then put it back in. Would that be a pragmatic solution, or is that just doing more guesswork?
Yeah, it's a good question. I certainly don't have the answer. I think the important part is the retesting. I mean, certainly for the non-IgE mediated allergies and the regurgitation sort of symptoms, we see a lot that the child gets put on an elemental diet and it bankrupts the family, and they never get challenged. So they never actually make a diagnosis. So I think that's where the key is, exactly like you said. My question is a little bit, would it matter if you then call it non-IgE mediated food allergy versus EoE? And I'm not sure. I don't know if we know that EoE due to cow's milk allergies as likely to resolve as non-cow's milk allergy. Maybe you can tell us.
I mean, you can induce remission, but the child might present at 4 again with a relapse and then have his. So it's not that this condition is a condition that is completely going away. We're talking, in allergy now for the first time in 20 years, we're talking about remission, whereas in the past, it wasn't a word that was used in allergy, but we're talking about remission and then relapses, and more like an autoimmune type of language that we're adopting. So if you think about it in that context, I still don't know. I think one has to address what's out there, what people are doing in absence of having been offered a gastroscopy. But on the other hand, that it's detrimental to have a child not having cow's milk until they're 6 and no formal diagnosis was made. So there has to be a re-challenge, and then at a year re-evaluation with a re-challenge. It's not an open-ended off cow's milk protein allergy for your entire life. Allergies have changed completely that way. And that, so whether you call it an EoE or a non-IgE cow's milk at that stage, the cow's milk needs to get back into that diet and they have to be retested. It isn't just this open-ended, leaving them forever with calcium deficiencies. And that's the other thing is if they on elemental formula, they don't need calcium. But once they turn 1, you need to start looking at their needs. And that's where the dietetics comes in, and that's where the cost comes in. And isn't it then cheaper to scope?
Yeah, and I think the existing evidence with EoE is that your clinical remission doesn't mean that there's histological remission, that there's ongoing remodeling and eventual fibrosis and stenosis.
Yeah.
So, yeah, I think the key then is to increase access to endoscopy and maybe transnasal endoscopy in these kids to avoid recurrent anesthetics, etc.
I think the transnasal is we'll work on a plan to get that. I think, I mean, certainly that is available, and it's available in older children, and it reduces, you know, all our angst about it significantly. So that might be a solution.
Agreed. Let me see. Is there any questions out there?
One question.
Everyone is silenced. I
I
think then, Miranda, what remains for me is just to give you a big, big thank you. I think we not only this afternoon tremendously appreciate your input, but also at Rahima Musa and equally so to the rest of the team. I see several of them online that really present a fantastic, you know, that have created a fantastic service for our patients. And I challenge everyone to emulate it everywhere, because certainly from what we've seen is these allergies are not less common in the disenfranchised population, and we're picking up so many of them. So thank you for that. Thank you for speaking today. And
Thank you very
then
much for having me.
pleasure. And then thank you to the University of New Mexico and the Gecko India team, who are technical support. And of course, thanks to the Gastro Foundation locally. We will be back next week, but the topic will be pancreatology. So thank you very much for attending, and we hope to see you again. Thanks, Miranda.
Thanks. Bye.